Well, thanks for having me today. I'm Emily Smith. I'm an epidemiologist from Baylor and Duke University. And today I'm going to talk about research. So I do research. I'm not an MD, I'm not a nurse, I'm an epidemiologist. So what does that mean? And what I typically try to do is translate epidemiology into policy. So I want to share that story of how that works with my own work. So first of all, what is epidemiology? It's a 7-syllable word that you can throw into any dinner conversation and sound like Jeopardy. It is not epidermis, so it's not skin, which I often get. It's epidemics, so it's a study of epidemics. It's also not this. It's not throwing a random wheel of coffee can cause, spin another one, depression in, and then spin another one, twins. That's not what epidemiology is. It's a discipline of science that is factual-based, evidence-based. So traditionally, the definition is a study of distribution and determinants of disease. Another way to say that is it's a population-level science. And so what is happening on a population level that would mean the disease would spread, or it would help not spread? Who is most at risk of a disease spreading or not spreading? That's epidemiology. The picture, though, of the mom and the child is the epidemiology that I consider myself doing, which is applied. So it has to matter to the people on the ground in those communities. And I'm a population-level scientist, so I deal with thousands of people. But at the end of the day, those populations are made up of individual people. So keep that in mind as we keep talking. So this paper was published about 12 years ago in the World Journal of Surgery. It is Surgery and Global Health, a view from beyond the OR, or the operating room. The authors are Dr. Paul Farmer and Jim Kim. Now, Jim Kim, these are global health champions for those of us who do this type of work. Jim Kim was the World Bank president. Paul Farmer is probably the most preeminent global health champion in terms of academics. He's at Harvard now and has founded a Partners in Health organization. So before 2008, global health had traditionally been on the big three: tuberculosis, malaria, and HIV, and rightly so, since that was burdening a lot of countries. Then they put out this paper about global surgery, and the world listened. Because when they say something needs to happen or shift in global health, people listen to these people because they're experts. What they said is, we've done a fairly good job with the big three. We still have a lot of work to do, but we need to move now into this field called global surgery. And the world caught on. We saw there's a new era of transitioning from what we call the Millennium Development Goals to Sustainable Development Goals. And the MDGs, or Millennium Development Goals, were very siloed. So we're going to focus on maternal and child health. We're going to focus on HIV care. The SDGs, or Sustainable, they broaden that to say we're going to eliminate poverty. We're now going to scale up healthcare systems. So it became not siloed, but broader in context that would encompass those silos. They also put an emphasis on the priority of health system strengthening and universal health coverage. And why this matters in global surgery is because they said global surgery is indicative of a good health system in a low-income country. In fact, there's Dr. Jim Kim again, a quote that you see from the World Bank. He said, surgery in a global context is an indispensable part of healthcare. So in other words, global surgery became on the agenda of global health entities at the WHO, the World Bank, and others. Probably the biggest one, though, was what is called the Lancet Commission of Global Surgery 2030. This was a group of commissioners from more than 100 countries that came together to not only define the problem of global surgery, but to also try to put forth a plan to eliminate the need for global surgery to meet that need. What they found, though, and when we're laying the foundation, was pretty stark. 5 billion people in the world are without access to safe, timely, and affordable care. That is a massive number when you consider there's 7.3 billion people in the world right now. They defined it, though, as how we would want it defined. If we needed surgery, we would want it to be safe, we would want it to be timely, and we would want it to be affordable. So when you define it like that, there's 5 billion people. But as you can see from the map, it is not equally dispersed. The darker the red on the map, the more of the need for surgical care. You can see in low and middle income countries, 94% of people are without access to timely, safe, and affordable care. In high income countries, it's only 14%. So an 80% differential in the need for care. So then they set forth, what do we actually need to meet that goal? We need to hire more people, we need to build more operating rooms, you need resources and staff. What is that gonna cost? And I'm an epidemiologist, so I'm thinking on a population level. In this era, it is the population of the world. It would cost this much, which always scares people when I throw it up, because none of us see this many zeros at one time. $12.3 trillion to meet the need for global surgery on a worldwide stage. Oh, I'm sorry, I skipped ahead. It's actually the deficit of 12.3. It's the opposite of what I just said. If we do nothing, it will cost the world's GDP, or gross domestic product, $12.3 trillion. In other words, it pulls down the economy of the world. So let me go to what I was trying to say. If we want to meet that need, it'll cost $350 billion. Not near as much of the cost of doing nothing. So on an economic scale, on a worldwide scale, it makes sense to scale up due to this cost to the gross domestic product in the world. So what do? I focus on kids. We've talked about global surgery for adults and kids clumped together. I focus on kids though, because in low and middle income countries, 50% of the population is children, which is very different than what we see here in the United States or in high income countries. We also know that up to 85% of those will have some sort of a surgical need by the age of 15. Now that is up to, and those can range in severity. Some can be congenital anomalies, like hydrocephaly or spina bifida, that are fatal. Others can just be a fracture that will not be fatal to a child, but it will be immobilizing. If you think of a child who breaks a leg and cannot get it fixed, they can't go to school anymore if it's not accessible. They can't walk and get water for their parents anymore. You just put your mindset into our own children. So some of the burden can be fatal, and some of it can just be demobilizing. Now, to set the stage for my work, we looked at seeing, is investing for children worth it as well? That 350 billion number was for everybody, but what about just segmenting out the kids, since we know they're the future of our world? The first paper that you see, Is Global Pediatric Surgery a Good Investment?, was trying to lay the foundation of it is a good investment. If we invest in saving children, making sure they can go to school, making sure that they're not impoverished by having a surgical need that their parents can't afford, it actually will improve not only the mortality of the country, but also the gross domestic product of that country. The next paper, the economic analysis of surgical care, was to see, is it cost effective? When I say surgery to anybody, probably the first thing you think of is it is expensive. If you get a bill in the mail from having surgery, it is expensive. We wanted to debunk that myth that it is expensive, but is it cost effective? In other words, in low income countries right now, we give out bed nets for malaria, or we vaccinate babies to protect them from measles. They had to do a cost effectiveness analysis to see, is it worth spending the money for those bed nets and the vaccines to do that? We did the same thing with children's surgery. You can read the paper, but at the end of the day, the paper said it is as cost effective as traditional public health interventions. And in some cases, it was more cost effective than some of the HIV treatments that we have for adults right now. So it makes sense to scale up for kids. So we know there's a problem. We know it's worth it to invest at this point. So what is the next step? And this is where my work comes in as an epidemiologist. This is not my kid. I wanted, as an epidemiologist, to go all the way to the country level and to try to define how much is it going to cost to scale up surgery for children for the entire country, not just one community. So I see it through this capacity building lens of moving through the cost of health economics and then all the way to policy. And so I want to spend the rest of the time showing you how you can do that in one country. What we have to do first, though, is go to the ground. Within the homes, within the individual levels at the household and the community, what is the number of children who actually need surgery? And of those kids, how many actually got it and how many didn't? That number of how many didn't is the unmet need. That is the need that we want to move to the met need. We want them to be able to get safe, timely, and affordable surgery when they need it. But how do you do that for a country with millions of people? So let me take you to Somaliland. Somaliland is in the Horn of Africa. It is East Africa. It is part of Somalia, but it is an independent state within Somalia. So it's a country to its own. On the border is Ethiopia, and then the northern border is Yemen. It's also one of the poorest countries in the world. It's the fourth poorest. It has a yearly GDP per person of about $348. Very, very poor. And when we think in terms of mothers and children, which is who I typically talk with, they also have some of the worst infant and mother mortality rates. If you look at the screen, to orient you, the top bar for children under 5, the top darkest bar is the rate for the world. The next one underneath that is the rate for sub-Saharan Africa, for all of sub-Saharan Africa. The next is neighboring Ethiopia, and then this bottom one is Somaliland. So the mortality rate for children under 5 for Somaliland is by far bigger than the comparisons. We see the same story for infant mortality rates, with Somaliland having a massive rate comparison, and also for mothers that are dying either from childbirth or post-birth. So Somaliland has the biggest indicator there. So it's a very poor country. Also, the healthcare system is not, it's recovering from a war that it had in '91, which is probably why we see the rates that we did. So I wanted to go to Somaliland and figure out, let's take this as a litmus test to see if we can measure how many kids need surgery, how many are getting it, and what is it going to cost to have those kids have that need met for the children. So step one was we had to go to the homes. We had to ask ourselves on the whole country level, how many need surgical care, who are they, where are they, how old are they? Are they all little bitty babies for congenital anomalies, or are they bigger kids with fractures? We need to know that so we can systematically scale up where it makes sense. So we did that. Now there's 2 million people, 2 million children within the country, so obviously we can't go to all of those homes to talk to the 2 million. In an epidemiologic way, you can do a random sampling of those 2 million and pick out about 900 homes that would represent the other 2 million children. So that's what we did. This is the country of Somaliland divided into its 6 regions. We had data collectors that went to all of the regions to about 900 homes and talked to 1,400 children or their parents and just asked them, have you ever had a surgical need? If so, where was it? Was it a fracture? Was it a head injury? Did the child die from it? Did they get care? Did they not get care? And a myriad of other questions. This was my student from Duke who lived there for 3 months and led this team of data collectors. And at the end of the day, I'm telling you, we're a population level science, so we have a lot of data to collect. This is what the end result of the data looked like. And she texted me when she got it and asked, how am I supposed to get these home? Which was a fun thing to overcome. These are our team of data collectors. We hired in-country Somali data collectors that would go to the homes, so they work with the communities already. There's a vested trust. It's not us going to the homes. These are midwives, they are medical students, they are nurses from the local hospital that I'll talk about at the end. But just a wonderfully dedicated team to go to all of these homes in very far remote regions from where they were trained. The next step, now that we have the equivalent to the 2 million kids is to go to the hospitals and see what surgery was actually done on the children. We're trying to build the story of where is the lack of the surgery. So who are they that got surgery? Where did they get the surgery? And what type of surgery did they actually have? Now, if you think about doing that, we wanted to do it over a 1-year time period. If you think about doing that here in Houston, to capture all the children who had surgical care in Houston over 1 year, it would take a long time. Even in Waco, where I'm from, it would take a long time because there's a lot of hospitals and a lot of surgeries. Unfortunately, from a data collection standpoint, in Somaliland, it didn't take that long. There are 15 hospitals that you can see on the map within the whole country that are capable of doing surgical care. 7 of them are in Hargeisa, which is the capital of Somaliland, and the rest are dispersed. So just imagine having a family in this most remote area of Somaliland. There's one hospital in the middle that families somehow have to get to if they need surgical care. So we went to all these hospitals and looked in their logbooks. They're not electronic medical record, they're in notebooks, and just wrote down who had surgery that were children, what type of surgery was it, and what was the outcome. So let me summarize. We went to the community, to the 900 homes, to try to get an aspect of who needs care out of those kids. And then we went to the hospitals and tried to answer, out of those kids who needed care, how many actually received care. So let me show you what we found. For the step 1 in the community, we found a prevalence of 13.7%. That's another way, an epidemiologic term of saying 13.7% of children at one point in time in the country need surgery for some sort of condition. Remember, we had the 900 homes to represent the 2 million homes. When you extrapolate that prevalence over the 2 million children, that equates to 246,000 children at one point in time in the country that needs surgery. Now, of those, that 246,000 is in this first bubble. Of those who needed surgery, 76% never received that surgery. And then an even smaller bracket, that did receive surgery, it was only minor, which is probably an indication of it was not full and therapeutic. It was almost a Band-Aid effort. Most of the conditions that we saw were congenital anomalies. You can see there's 34 were congenital anomalies, so the babies were born with these conditions. 24% were wounds, 12% were burns, and then you can see the others. So a large amount of congenital anomalies, more than what we see in neighboring Ethiopia. So let's move to the hospital perspective. We know that 246,000 kids need surgery. How many actually received that surgical care? And this is a 1-year time period, so it's not a direct equation from the 246,000 to this, but it'll tell a little bit of the story. So over a 1-year time period, there were 1,255 surgeries done on children at 15 hospitals throughout the whole country. The majority of those were in that urban capital, where 7 of those hospitals were in Hargeisa. Most of the surgeries were done there. This is one of the families that received surgery for a baby that had hydrocephaly. The anesthesiologist that you see is Dr. Mubarak Muhammad. He is my data manager, in-country data manager for this portion of the study. We also were trying to ask ourselves, if only 1,255 kids got surgery over a 1-year time period, why was that the case? And there's a myriad of reasons, but one of the biggest factors was workforce. You have to have a nurse, you have to have an anesthesiologist, and you have to have a surgeon. So we looked at that. We found that there were 38 surgeons throughout the country. 21 were in the capital of Hargeisa. 43 providers that could do anesthesia. These were nurse anesthesia personnel. 1 pediatric surgeon in the capital and 3 trained anesthesiologists in the capital. So when you equate that to trying to cover a population of 4 million people, it's a ratio of about 2.47 per 100,000 people. This juxtaposed to what the goal is for low-income countries. Our goal is to get to 20 per 100,000 people. So there's a wide gap, but it's telling us a story. It's laying the foundation for us to ask for a scale-up model. So let me summarize again. We're going back to our building the story. About 250,000 kids need surgery at the community. 1,200 of them had a met surgical need or had surgery. That means that we have an unmet need of 248,000-ish surgeries that are needed. So our goal now is to figure out how to get those kids with an unmet need to the met need. But we know that telling the rest of the story is not as simple as taking them to care or making sure they get to care. We have to ask ourselves the question, why aren't they going to care in the first place? That was going back to the families, to the mothers, and asking, if your child needs care and you weren't able to go, then why? And we found two prominent reasons why. The first was it was too far to get there. This is what we call a geospatial analysis. It's a powerful tool to actually use GPS and geolocations to pinpoint where are the hot spots of the need. I want to show you where Hargeisa is to orient you to the country, the capital city. These green areas say that anybody who lives within that range can get to the hospital in Hargeisa, or those 7 hospitals, within 2 hours, which is our goal. It's the global goal. Anybody else outside of that realm, which you can see all the other different colors, means that it's more than 2 hours to get to the care that they need. If you put that in a percentage, it's about 80% of the country can't get to care within 2 hours. And if you think of a fracture, if you think of a kid falling out of a tree or needing some help with an acute condition, then 2 hours really matters. So one of the biggest barriers was this geography area. We were also able to pinpoint what about, are there certain ages of kids that are affected more than others. And that's what you're seeing here. In this top box are little children, 0 to 5. Where you're seeing the hot spots up here is where the prevalence of unmet need is the biggest. So when we're thinking of scaling up, we want to go there and figure out how to meet those needs. Most of those are congenital conditions. For 6 to 10-year-olds, we have a hot spot in this region and a hot spot over here. And then for older kids, we have kind of this global darkening through this whole swath and then a hot spot right there. So it's just refining the model, refining the story of where we need to go. Now the second portion of this that was probably the most prominent on not getting care, not being able to get care that they need, was poverty. I showed you this family earlier with Dr. Mubarak. They traveled 4 or 5 hours by bus, and they have to continue coming back to get care. Now, to be able to get care, they have to sell assets, camels. They have to figure out where to get the money from family members every time they come. So you can just imagine what that does to their livelihood or being able to pay for food or other health conditions they may have. So we wanted to see who's at risk of this being an acute surgical need becoming an issue for these families, because sometimes it might not be. We used what's called the stages of progress model. And what this does, you see the slope. It means that at the beginning of time, you have families that start out not impoverished. They're doing okay. Something happens though, an acute healthcare event happens, a heart attack if we think about here in the States. But I wanted to see if an acute surgical need would throw those families into poverty, which is this loop, and they would not be able to climb out. Or is it just acute and they're able to climb out? That matters for us doing economic work. So we tested that. We asked the families, did that have any type of influence on your finances? Were you able to come back out of poverty and recover after that surgical need? And here's what we found. Among all families, the people in blue, that 12.5% of people, those are families who moved down into poverty and never came back up. The middle group, 61.5%, are families that stayed the same. The surgical need that they had or non-surgical need, it was okay to their finances. And then 26% families moved up out of poverty. So we see an ascent. But is that the same for families who need surgery and families who don't? This is all 900 homes, and not all 900 actually had a kid who needed surgery. So we took those apart. And what about the families who had a child with a surgical need and families who didn't? Of the families without a child with a surgical need, 10.8% moved down to poverty and never came back up. 62% stayed the same, and the remaining 27% moved up. Remember, these are families with no child with a need. However, with the families that had a kid who needed a surgical need, this is where we see the difference. Almost 20% of families moved down into poverty and never came back up. 59% remained the same, and then 21% moved up. So look at the difference of the families who went into poverty and never recovered from those that did not have a child with a surgical need versus those that did. It's almost a doubling. So poverty not only was a barrier to get to care, probably because of geography, and you have to pay for the transportation, it was also a strong predictor of poverty and not being able to recover. So that brings me to the next step. We now know the model, we know the need that we need to overcome. We know some of the barriers to overcome of geography and poverty. Now this next portion is the the macro approach. And the way to do this is, if I'm going to ask for $2 million, what is that going to do in terms of saving a child? If I'm going to ask for $50 million, which is probably more likely what it's going to cost, what will that do to the country? It's a cost-benefit analysis. And from an economic standpoint, we do it all the time. If you're going to pay for bed nets for malaria, how many infections will we reduce because of that? So we haven't done that yet. This is our next step that we're working on the cost-benefit analysis. It talks very strongly to someone like the United Nations and the World Health Organization, because you can equate it to $1. Give me $1, what is the bang you get for a malaria bed net, but what's the bang you get for a child with a surgical need? It's a powerful tool to use. So let's put it all together. We started at the bottom of the epidemiology, the data collection, how many children needed surgery, how many got it. We're now moving to how much will it cost to impact the whole country, and then what will be the impact? In other terms, how many babies would we save? This last part is policy. It's a national plan development, or it could also be at the United Nations level. It's trying to get at the highest level of the Ministry of Policy. You could think of it being our own Senate and Congress, trying to get plans in place that would ensure children can get free surgical care when they need it, or at a discounted rate, or anything in between, to make sure we protect those families from poverty. Probably one of the funnest parts of my job is I got to see this in action with some of my colleagues back in April. We were invited to go to the Universal Health Coverage high-level meeting at the United Nations, which is what you see here. And they asked multiple entities, multiple stakeholders to come and sit at the tables, which here's with my Duke surgical colleague. He's the chief of general surgery at Duke Medical Center. And every stakeholder had a different voice. We came in and we wanted to say, if we want to make universal health care coverage worldwide and protect families from poverty, we need to make sure that surgery and protection from surgery is in those plans. The other stakeholders were coming from all other different avenues. There were maternal child health advocates, there were HIV advocates, there were elder care advocates. So in all one voice, we tried to incorporate those voices into a document that later on went to the General Assembly at the United Nations in September, which is where this is taken. This is the World Health Organization president. You can see me fangirling over meeting him in the hallway. But this document went before the United Nations of for universal health coverage, make sure surgery is in there. And of course, so many voices were there. So it was limited of what actually went in, but we were heard. And the beauty of it is it started from the data, advocating through evidence-base to try to advocate on the highest level for surgical care for kids to be impacted and to protect those families from surgery. Now I want to end on this. This is part of Somaliland, it's part of my team. And I want to end and certainly highlight who you see down in this area. This is Tessa, she's a student I told you about. So for the students in the room, just dream of what you can do with research and data collection. And we probably have no idea what that will impact months or years later, but it matters to do things in excellence. This is our team of data collectors being trained before they went out. And then this lady is Dr. Edna Adon. She is the global champion within the country, which in global health work is probably the most important factor for any of us to do, is making sure we have a champion within the country who lives there, who's from there, who knows the context, and can champion this effort while I just get to help do the data portion. Edna is from Somaliland. She went back after being decades long at the WHO and a diplomat, and she took her pension out and built a hospital, which is what you see here. It's one of the biggest hospitals in Somaliland. It is within Hargeisa, but this is where my teams will stay. The midwives that you saw and the medical students are from her hospital. So her visioning and goals of improving care for the country has really been what has elevated this project. If you want to know more about her, you can read the book Half the Sky or watch the PBS documentary on it. It was a book written about women across the world that hold up half the sky, and she was featured as one of those prominent. So just a global health champion. It's a reminder to have friendships and relationships with people. So with that, this is my team that I'm still working with. Dr. Shukri is another one of our data managers. She's one of the only female surgeons within the Horn of Africa, but we remain to dive deeper into the data, to collect more data on telling the full story for these families to try to advocate for care. So thank you for listening to me today.